Good evening, everybody. Welcome to our microsampling seminar titled Better Sampling to Support Effective Dosing. We're starting with the acknowledgement of country. The University of Queensland acknowledges the traditional owners and their custodianship of the lands on which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognize their valuable contributions to Australian and global society. We have a very interesting program today. We have international and local presenters. I'm Patty Mitri. I'm a postdoc researcher at Professor Jason Roberts' team in the antimicrobial optimization group. And our first presenter will be talking about the evolution of microsampling to support therapeutic drug monitoring of new antimicrobials in adults. Our presenter is Dr. Pier Giorgio Cojutti, Medical Director of Pharmacology, University Hospital of Bologna, Italy. Dr. Cojutti is a medical doctor. He completed his clinical pharmacology residency and earned a PhD in pharmacology at the University of Udine, Italy, and had a postdoc fellowship at Liverpool University, UK. At present, he is consultant clinical pharmacologist at the Clinical Pharmacology Unit of the St. Ursula Malfigi University Hospital of Bologna, Italy. His hospital activities focus on TDM of antimicrobials in complex patients with severe infections and critically ill patients. He is author of more than 100 original research papers in the area of anti-infective chemotherapy, with a particular interest on population modeling and on PK/PD relationship linking exposure with different biomarkers of response. He currently serves as reviewer of several infectious diseases and clinical pharmacology journals. Welcome, Dr. Cojutti.
Thank you for this kind invitation. Thank you, Jason, for inviting us in this interesting topic and new topic with promising implementation in TDM, especially with new antimicrobials TDM for new antimicrobial TDMs in it. Just a brief recall to show you some of the benefit of microsampling, both in terms of sample collection and application. Some of the most important benefits for sampling collection, for blood sampling collection, are the fact that microsampling is minimally invasive and thus allowing for at-home self-sampling. So it is useful for TDM, for patients living far away from medical centers, for example. Moreover, it enhances analyte stability, and so also the shipping of the samples is feasible and is allowing facilitation for TDM, for application for TDM. On the other side, in terms of application, I think one of the most important advantage of microsampling is for remote monitoring and for intensive PK/PD analysis or even studies. And so the main focus for application of microsampling are, of course, in special population like neonatal and pediatric patients. And I know that the next speaker will talk specifically on this topic, so I will not mention this. And for as well as for TDM, as I told you, specific situation of patient living far away from medical center. I would say these are the most actually important topics for implementing microsampling. There are, however, some issues that should be resolved before a widespread implementation. One of here I write down 4 of them. The first is the fact that microsampling should ensure a good quality specimen in terms of collection, and this is not easy because the different metrics applied may in some way bias the type of blood sampling that is collected. Not to mention the hematocrit problem. This is true with the initial dried blood sampling matrix. The fact that the third point, the fact that most devices are still expensive nowadays is another limit of the widespread use of microsampling. And the fourth point is a lab point. So it is necessary that from a laboratory point of view, analytical methods are developed in terms of ensuring sufficient sensitivity to manage very low quantity of patient samples. And I show you in the last part of my presentation some of the methods we developed at our center explicitly with this intent. This is just a slide showing how many type of microsampling devices are currently present on the market. It is out of my scope to illustrate you every single detail, just to categorize a bit, and for some orienteering, you can divide the microsampling device into two broad categories in terms of dried matrix and liquid matrix. These are the two main type of microsampling. The first developed are those with that use dried blood sample in terms of collecting dried blood spot or plasma spot or dried serum spot. We start using at our center the dried plasma spot matrix with the telemune card that I show you in the next slide. Then another differentiation is between dried matrix spot and volumetric microsampling, which means that a specific volume of a precise volume of sample is collecting rather than a simple drop blood, which is imprecise. And the liquid, and the second part is the liquid microsampling, which, as far as I know, is less used in medical center. This is the dried plasma spot card, the telemune card that we start using. You can see on the left-hand side of the slide the card. The blood drop is put into this white circle with. There is a control, a red control here if everything goes well. And then after 3 minutes, the surface of this card is removed, and the disc that remains at the bottom of the card is then extracted and shipped or analyzed. Here on the hand side, you can see the structure of this card. The particularity of this card is that within the card, there is a sort of chromatographic run in which the blood drop here runs, and at the end, plasma is extracted and put in this collection disc, which at the end represent the matrix that is analyzed in the lab or shipped wherever you want. Using this, I show you now 3 small clinical cases of oncohematologic patient where we use the telemune card. So the first case is a young child, male, 4 years old, affected by juvenile monomyelocystic leukemia, which is a rare hematologic disorder characterized by a proliferation of myelomonocytics in many different organs, the liver, the spleen, and for which the only curative therapy is hematopoietic stem cell transplantation. Well, this patient here, this small patient, underwent HCST. He is at 16 days from HCST when he developed fever, 39 degrees, and CRP increased at 7.5. He was already on antimicrobial chemotherapy for viral and fungal prophylaxis, and so he started piperacillin tazobactam, the anti-infective piperacillin tazobactam for empirical treatment of this febrile neutropenia. The PK/PD target for targeting piperacillin tazobactam are, as you, I think, know, a ratio between the trough concentration and the MIC between 4 and 6, which correspond in the empirical setting of targeting concentration of piperacillin above 32 milligram per liter, and for tazobactam a concentration greater than 8. So we at 3 days from starting therapy. Here are the concentrations sampled by means of the microsampling, which were 3 and 0.47 milligram per liter, which are low concentration. In fact, the patient had no response to therapy, and so he was escalated to meropenem and prosecuted his treatment. A second case is very similar. It is a male patient, 4 years old, with a relapsed acute lymphocytic leukemia who underwent HCST. It is at 6 days from HCST and he developed fever. Even here, no microbiological isolate were retrieved. He started empirically piperacillin tazobactam this way by continuous infusion. And here you can see dosage, 400 milligram per kilogram per day by continuous infusion with the same PK/PD target as I show you in the previous slide. TDM at 48 hours revealed concentration of 51 and 4.7 milligram per liter, so effective concentration. The patient was clinically stable and fever ceased in 3 days. Of course, these are just this concentration that in the first case where we'll see low concentration, and here are quite good concentration, can of course ensure that can explain that the response was bad in the first case and good in this case. There are a lot of clinical factors that can affect clinical condition. But from the exposure point of view, we can see that in the first case, by intermittent infusion, concentration were low, and here concentration were effective. The third case is quite different. Is a 13 years old child, with a relapsed acute lymphocytic leukemia at 11 days from his ACST. This patient was affected by bloodstream infection with clinical isolate. An Enterobacter cloacae was isolated with this particular gene of resistance. VIM is a metallo-beta-lactamases, one of the most aggressive gene of resistance, for which the treatment, if feasible, is driven by meropenem. Here, meropenem MIC was 1, and so it was put in meropenem plus amikacin by continuous infusion meropenem treatment. However, after some days of treatment, of effective treatment, his CRP increased up to 40 milligram per deciliter, and so treatment was changed to ceftazine-avibactam plus aztreonam, which is the second-line treatment for metallo-beta-lactamases Enterobacterales. Ceftazine-avibactam was put by continuous infusion, and aztreonam at the doses that you can see here, 2 grams every 8 hours. TDM was performed after 2 days of treatment by microsampling, and here the concentration of ceftazine-avibactam were over 248 milligram per liter, and interestingly, the day after, so at 3 days from starting treatment, quite the same concentration, high concentration, were revealed by standard sampling of 168. So these are quite high concentration. The patient was clinically stable and his CRP reduced from 40 to 7.32 milligram deciliter. If this is interesting from a clinical point of view, as I told you, it is also important from a lab perspective to develop the effective methods to detect and to sample and to detect very small quantity of sample and of analyte. In our lab, all our methods are developed by using HPLC tandem mass spectrometry. These are the details of our instrumentation, and thanks to this, we developed 4 methods for newer antimicrobial that very shortly I will show you in the last part of my presentation. The first method we developed is for dalbavancin. Dalbavancin is a quite new and interesting antimicrobial for the treatment of multi-drug resistant gram-positive staphylococci. It has a long half-life, and for this reason, it is used mainly for the treatment of subacute and chronic infection, mainly prosthetic joint infection, osteomyelitis, spondylodiscitis. These are, of course, all off-label indication, but the role of for dalbavancin in treating this patient is very interesting because this treatment may last for month or even year. We have we have a patient treated with dalbavancin with therapy lasting 2 years. And so the role of TDM in this case to target appropriately dalbavancin concentration is pivotal. We developed a method also based on TDM and Bayesian approach to forecast the time that the effective concentration remain above a specific threshold of efficacy. And thanks of microsampling, it is possible to tailor therapy of this type of patient who live far away from our center, who are often case elderly, and for which traditional sampling may be complicated. Here is the detail of the method. The method relies on 3 microliters of patient plasma, which is appropriately then treated in order to guarantee nominal concentration that start from 0.125 microgram per milliliter to 280. And here you can see the calibration curve, and with good average, with good precision and accuracy across this concentration. Normally, the range of dalbavancin is between 10 and 30 milligram per liter. So this calibration curve adequately capture this type of concentration. The second method was developed for meropenem vaborbactam. Meropenem vaborbactam is a new beta-lactamase coupled with beta-lactamase inhibitor, which is specifically prescribed for the treatment of KPC, Klebsiella-producing carbapenemase infection, Enterobacterales mainly. Ceftazia avibactam usually is first line. Meropenem vaborbactam is second line antibiotic. This antibiotic, as you can see from the table on your right hand side, has a unique spectrum against this KPC producer. It is mainly ineffective against all the other gram-negative multi-drug resistant bacteria. We developed a method similar to the previous one. We're using 3 microliter of patient sample, and here are the nominal concentration from 0.1 to 75 milligram per liter of both meropenem and vaborbactam. In this type of new beta-lactamase plus beta-lactamase inhibitor, it is important to determine the concentration of both the analyte of the beta-lactam and the beta-lactamase inhibitor, because the joint PK/PD target is should be appropriately targeted. The third method was developed for cefiderocol. Cefiderocol is another beta-lactamase, which is used mainly for some strains of Pseudomonas aeruginosa and Enterobacterales, especially those carrying the metallo-beta-lactamase gene of resistance, the AM or the IMP, but especially its mainly used is against infection caused by Acinetobacter baumannii carbapenem resistance. This is the main place in therapy of cefiderocol, which unfortunately in our part of Southern Europe are quite frequent. Again, for cefiderocol, a method starting from 3 microliter of plasma sample was developed with nominal concentration from 0.1 to 150 milligram per liter. It is stable with good precision and accuracy. The fourth method that we developed was that of fosfomycin. Fosfomycin is an older drug, as you know, which is used in combination with different antimicrobials, both against Enterobacterales and against Staphylococci. So the use of fosfomycin in combination therapy increased the efficacy of the first antimicrobial, which could be daptomycin, which could be even some beta-lactamate. And here you can see that for different type of infection, fosfomycin dosage that could be used may go from 8 gram by continuous infusion to 16 gram by continuous infusion. Phosphomycin, again, is sampled by microsampling with a plasma sample of 3 microliter and with a nominal concentration quite high from 1 milligram per liter to 800, because the problem with phosphomycin is, unfortunately, there is no clinical breakpoint, and so it is quite difficult to identify a proper range. And so what we do usually is to hypothesize kind of a specific MIC, like 16, 32, 64, and we see, okay, with this concentration, your exposure is enough for an hypothetical MIC of 32 or 64. We use phosphomycin by continuous infusion, and we saw that in many situations we use reduced dose, which is quite effective for phosphomycin because it is associated with sodium and potassium load, so an ion load, which impairs in many patients, like critical ill patient, the use of phosphomycin. So the fact of targeting hyperpletic phosphomycin is with TDM is important. So to conclude, which are, in our opinion, the promising application of microsampling, of course, in neonatal children for obvious reason, and this I think that the next speaker will tell you every details on the application on this particular population, but even for outpatients with dalbavancin, for instance, elderly patient, for instance, who can't come quite often to your medical center may benefit from microsampling, and from a research or scientific point of view, even PK/PD studies where intensive sampling should be required. Well, microsampling may offer you a good advantage from this point of view, provided that implementation in terms of prospective studies comparing microsampling with traditional phlebotomy are carried out. So I thank you for this invitation, and I finished. Thanks.
That was wonderful, Dr. Cojutti. Thank you very much.